Thank you for joining us tonight for Living with Scoliosis. Tonight, we're going to discuss scoliosis diagnosis, treatment options, and life after surgery. So, our speakers today, we have orthopedic surgeon Evan Chiha, and we have physical therapist Maria Carcina, and we may have Dr. Dowdell join us at some point. He may pop in. He's working with some patients right now. It went a little later than we thought, so he may come on at some point, and we'll welcome him then. That we will get started. So my first question for you two is, how is scoliosis diagnosed in adults, and what are some symptoms that people should watch out for, or how can they know if they need to go and get a diagnosis?
Yeah. Thanks, Mike. Well, thank you for the introduction. It's nice to see everyone here. Thank you guys all for coming tonight. So we'll jump in with that sort of that's sort of where things start, I think, for a lot of patients. It's, the question of, do I have scoliosis? A lot of people are, you're born with it. It's called adolescent idiopathic scoliosis. You know about it since when you were a child. Maybe you had some treatment. Maybe you were in a brace, or maybe you went to an orthopedic surgeon or a neurosurgeon in the past and you had some x-rays done. So you're aware that you have scoliosis, and you've been counseled in the past about this is what to expect over time. You may see some progression, or we anticipate that this will be stable. But a lot of times it can arise in older adults. It's part of the aging process for some people, and the way that their spines sort of evolve with time, and some of the effects of aging on the spine can lead to scoliosis. We'll get into that a little bit more. But with regards to the question, how is it diagnosed? So the best way is, things that you might notice as a patient. You might, start to feel an increased rib hump, or an increased hump in your lower abdomen, or in the lower back. You can also start to see a progressive change in your standing posture, whether it's that you're pitching forward more, or that you find that you're curving to the side a little bit more. So worsening posture might be an indication that you do have scoliosis, or the beginning of scoliosis, or maybe scoliosis that's been around and starting to progress. Another part of it, because you have a curve, oftentimes a curve in the front plane, or the coronal plane, is part of this. Nerves can be pinched as they're exiting the spine on the side of that curve. So you might actually start to feel some pain in the legs. We call it radicular pain. And in terms of next steps for diagnosis, presenting to either your primary care doctor as a first step, or if you're able to get in to see one of us at HSS, or able to see a spine surgeon or physiatrist, the next step is to do x-rays. So a lot of times people start with just x-rays of the lumbar spine to get a sense for what's going on, kind of based on your complaint. But otherwise, you can get full-length scoliosis films. There are a number of different ways that we do that, either with a large cassette, one large cassette that looks at the front of the spine, the side of the spine, to get a sense of your profile. And also, there are other newer imaging modalities, like an EOS film, where we can actually take an image of you from your ankle up to the top of your head, or from your spine, from the front and the side, in one shot, and it can give us a good sense of what's going on with your spine, your overall alignment, and allows us as spine surgeons to make some measurements and come up with what might be the next best treatment plan, or to get a better sense of your spine. Otherwise, we use those films. Say you're doing well and you're just coming in for a first diagnosis, we're going to use those films to follow you over time. So it's a snapshot in time, and we can use that as a baseline to see if things progress, if things change over time, and then modify the treatment plan accordingly. Another way that it's picked up too, oftentimes, is that if you go for another type of scan, maybe you need an abdominal CT scan, or an MRI of your abdomen for some reason, some other process is going on, and it's noticed. And there are some patients that show up in my office and say, I got a CT scan of my abdomen or my pelvis, and they noticed that, hey, you have a scoliosis, or there's a big curve here, maybe you should get that checked out. So that's another way that people are diagnosed with scoliosis. But really, it's symptom-based, and then we confirm it with imaging studies, x-ray, typically.
Okay, thank you. And similarly to that, how can someone tell if they just have general back pain or if it's really scoliosis, and how should they know if they really need to go to the doctor?
Yeah, so certainly, low back pain, these two can coexist. So people with scoliosis, they don't always have back pain, and people with back pain don't always have scoliosis. But certainly having scoliosis puts abnormal forces on the joints in your back, the facet joints, which are the joints in the back of the spine, as well as the disc spaces in the front. And in doing so, like I mentioned before too, you can also have nerves being pinched as it exits the spine from a lot of extra ligament or bone that's formed in the spinal canal that pinches on nerves or pinches on the sac of nerves in the back. And so you can ultimately develop symptoms that way. But like at the end of the day, in order to determine if it's just general back pain or scoliosis, you probably need to go see someone. If it's becoming bothersome, it's not responding to medications, it's not responding, it's sort of affecting your day-to-day life, going in to be evaluated, diagnosed with an x-ray, and obviously an examination from either a primary care provider or an orthopedic surgeon or a spine surgeon is the next step to really confirm what that is, put your mind at ease so you can understand what is going on and develop a treatment plan, and then go from there.
All right. And Maria, have you ever had someone come in for physical therapy and they thought they just had regular back pain and you kind of noticed that it was more than that, or that you were, curious and having to do further treatment with them?
So very often in elderly population, we see that people when they come with the back pain, they have some misalignment of the spine. And it could be degenerative changes or just scoliosis since they're in children. So what I find that if we address their spine misalignment through the postural correction exercises and it helps, so I assume that the pain was coming from scoliosis. And if it doesn't help, we just look for other impairment or muscle imbalance and we address that.
Okay, great. All right. And what my next question is, what causes scoliosis? Is it genetic? Is there other factors at play that, cause this?
Yeah, certainly. So for the first sort of the kind of scoliosis happens when you're young, we call it adolescent idiopathic scoliosis. So that's one version of it. You can also have scoliosis that's driven by neuromuscular disorders, and there's a lot of younger patients with scoliosis that have a coexisting neuromuscular disease that maybe causes a muscle imbalance and causes the spine to not grow in the typical straight way, and you end up with a curve while you're young. That's mostly genetic. That's a little bit different from adult scoliosis. So a scoliosis that develops in adults, I think we can get into the other different types of scoliosis, but largely for adults with scoliosis who develop an adult spinal deformity, it's typically the result of degenerative changes in the spine, could be the result of poor bone quality. You may have compression fractures in the spine due to osteoporosis. You can have disc and facet wear and tear, and over time that causes a bit of a degenerative cascade as the facet joints and discs wear out, and it can compound the curve that's happening in the spine. So basically what happens is the disc loses hydration and its normal height, the disc in the front of the spine. When that happens, it typically happens asymmetrically, and you end up with a bit of a curve, which then can progress over time as the degeneration progresses over time. This can cause the vertebral bodies to shift. This can cause you to lose the normal, not only the curvature in the frontal plane, but also looking at you from the side. So you can start to pitch over a little bit more. You might find that you're hunching or leaning forward. But that's typically, adult scoliosis is typically the result of degenerative changes that happen normally in everyone's spine over time. There's certainly genetic components to it, but it is a degenerative process at the end of the day when it happens in adults.
Okay, thank you. And can you tell us a little bit about the different types of scoliosis? I don't know if that's, going to be too in depth to talk about all of them, but kind of explain, who gets which kind of scoliosis and, what people should expect if they think that they might have one of these types.
Yeah, no, I think it's a good way to think about it too. So I sort of mentioned in the last question, or the last question you asked, there's certain types of scoliosis that affect younger people. So those are the idiopathic scoliosis, neuromuscular scoliosis. There's early onset scoliosis that affects infants. But there's also, different varieties that affect older adults. So you can have the degenerative type of sort of de novo scoliosis that happens, the one that I just described. Also, if you have a spine deformity or like a post-traumatic spine deformity. So when we think about scoliosis, we think about it in 3 dimensions. And I've mentioned this a few times and will continue to do so. It's not just the curve in the front plane, like that S curve that you see, but it's also pitching forward or loss of the normal curvature in the side profile. So we typically have lordosis in our spine. Let's see if I can grab a little spine model here. I don't have a full one, but I can give you a lumbar spine. So typically, if we're looking at the lumbar spine, we have a little bit of this curvature to the back we call lordosis. And then in the thoracic spine, it corrects up to the top so that you end up with your head centered over your pelvis. We think about scoliosis as a 3D deformity. So even if you're starting to pitch forward, we might call that kyphoscoliosis, or kyphosis means more forward curvature of the spine and loss of the normal sagittal profile looking at you from the side. So you end up, being more forward. You start to do compensatory mechanisms to stand up straight in the world, and that's one, that's another sort of the can result from trauma, can result from degenerative disc disease, and occasionally can also result from having been fused in the past. We as spine surgeons, there's more and more literature coming out about the importance of maintaining that profile, even if we're only doing 1 or 2 level fusions, which is a fairly common thing that we do in the spine world. But historically, some of the ways that we fuse the spine would flatten that spine out. As a result, you'd have to compensate either by tilting your pelvis back or flexing your hips or trying to arch back at the level above that fusion. And as a result, you can sort of accelerate the process of wear and tear, and you may need another fusion in the future. So we're trying to be more cognizant of that now, but certainly, and we call it iatrogenic scoliosis, or the result of a fusion, means it happened because you had a fusion done. In the past, we used to use things called Harrington rods. Harrington rods are basically long straight rods, and maybe some in the audience who'd been fused with a Harrington rod in the past. Long straight rods that we'd put on the inside of the curve, and we would open them up to straighten out that curve. In doing so, we also straightened out the sagittal profile, or looking at you from the side, resulting in something called a flat back deformity. So you lose this normal curvature of the lumbar spine, ends up flattening out, and that is a source of pain because you have to sort of compensate in the way that you stand, in the way that you hold your posture and hold your body. It's taxing on the muscles and taxing on the joints and disc spaces in the spine, and that can accelerate some of the pain that's associated with scoliosis. So those are really the major forms of scoliosis. There's another one that we think about too. Occasionally, just having compression in your spinal canal or central stenosis can cause us to hunch forward because we're doing it as a mechanism to open up the spinal canal. So that's where the importance of the x-rays, the evaluation, taking a good history, and then also getting additional imaging like an MRI can help us to determine if this is, what is the driver of the scoliosis? Could it be coming from a compensatory mechanism that you're doing? Are you leaning forward because your body's sort of telling you to do that because otherwise it causes leg pain or causes your legs to feel heavy? Or is it coming from a more organic or pathologic process of degeneration, or maybe even another process that had been going on from early on in childhood?
Thank you. These webinars always remind me to sit up straight while we're talking about this.
That's right. That's right. I unfortunately have poor posture, but I do try and remind myself, especially when I'm sitting in there in the office with the patient and I'm slouching around. So it's important to do that just to keep those muscles activated too. I mean, Maria could probably speak to this. Good posture is just good for it helps your back feel good. It's not going to change your scoliosis, I think, over time. That's a process that's set in motion by some of those degenerative changes that happen, but it's activating the core muscles, it's activating the paraspinals, and it's helping to keep your posture erect, but also keep those muscles strong over time. If they're always active and firing, they're going to be able to be active and firing for longer periods of time. So I'm sure that's something, Maria, that you preach to your patients, that, good posture has so many more benefits. It's really not going to change the natural history of the scoliosis, though in some ways it may. I guess we'll get into that if we talk about Schroth later on. But that's probably something that you preach on a daily basis.
Yes, definitely. I agree that just correcting postural alignment relieves so much stresses that go through the spine and the trunk through the day, and just the muscles that are tense all the day due to the misalignment get to rest, and that helps to relieve pain on its own.
Yeah, definitely.
Yeah, so, and that's, just to jump in, because one more point, that's why people don't typically, we don't suggest bracing for adults with scoliosis. That's like a last ditch effort kind of comfort thing that maybe you as a patient have determined, I feel better when I wear this brace if it's just a lumbar like a soft lumbar corset. But we put younger patients in hard braces to try and guide their growth and see if we can affect the natural history of the scoliosis. But in older patients, all that's doing is really shutting down the muscles that need to be working, the core muscles, the paraspinal muscles, all those important muscles. And if they're not working and firing throughout the day to help hold up your posture, then you're ultimately doing yourself a detriment. It may feel good while you're in the brace, but you're really not going to be in brace all the time. And when you come out of it, those muscles are not ready for the kind of action that they're going to be called to do. So it has a bit of, it's a bit of a double-edged sword. It can be good for some pain relief, but it's not typically something that we recommend in adults for that reason, because it's sort of, it negates the good effects of having a strong core musculature that can support the scoliosis and keep some of that pain at bay.
All right. And speaking of bracing and more kind of, I know you said you recommend that for children, but can you talk about some non-surgical treatment options? And I also want to ask Maria about kind of go over briefly what you normally do in physical therapy with someone with scoliosis.
Yeah.
So
no, go ahead, jump in, Maria.
At HSS Rehab at 75th Street, we provide a short method, which is scoliosis-specific exercise approach, and it consists of postural correction, spine stabilization, core and back muscle strengthening, and breathing exercises. So it is an 8-session program, and where you learn 6 to 7 postural correction exercises designed specifically to your curve type. And during your program, you also receive guidance on how to sit, stand, and sleep in positions that relieve these postural stresses. It is an intensive program, and it requires you to spend 30 to 45 minutes of doing these exercises at home on your own. And your home exercise program is a lifetime commitment, and it is vital in order to maintain your postural corrections. So for these reasons, we also offer review sessions every 4 to 6 months to go through those exercises specific to your curve. If you feel that the program is intensive for you, we may transition you to regular physical therapy at our site for general strengthening, core strengthening, back strengthening, and conditioning exercises.
Maria, do you need any special equipment if you're going to do this at home? If you're prescribed a Schroth program at home? I know I've seen from some of the literature I've read. I myself haven't seen Schroth practiced by a physical therapist. Unfortunately, I haven't had the chance to get in there and see it, but I've certainly read several papers on it. And there seems to be some apparati that are used. Is that something that patients would need at home, or is that something they can usually adapt something that they have in the home.
So in our clinic, we use short bars. This is just regular wall bars where we do this hanging stretch exercise that helps to traction the spine. And at home, I usually recommend just getting pull-up bars that are overhead pull-up bars that could be used for these hanging exercises. We also use belts for the floor exercises to create traction of the spine. Again, stretching out the spine and stretching the muscles of the convex side of the curve. And we also use the bean bags that we place specifically under the prominence of the ribs that helps to guide and push ribs towards the opposite side of the rotation of the rib cage. But it helps with improving the rib mobility and of course in respiratory function, and it helps then in upright positions to correct the posture.
Sure.
So wall bars,
Mhm.
bean bags, and the belts that help this traction.
Gotcha. So let's say, let's say someone comes in and the Schroth method seems like a little daunting for them, but they're interested in doing some physical therapy for the back. Are you able to modify some of those things so maybe it's less intensive, or are there other programs that you give to patients who maybe don't fit into the Schroth as maybe the best method, or it's too time intensive? Are there other directions that you can take them?
Yeah, so basically what I do when we go through the evaluation of the patient, I evaluate not just the curve and the type of the curve, but regular functional limitations the patient may have, or weakness maybe in their hips or limited mobility in the hip. So as a Schroth and orthopedic certified therapist, I address all the limitations. And I always encourage to try for a few sessions to do these exercises, Schroth specific exercises, and see how it feels. In the beginning, it really feels too intensive, but spending just 2-3 weeks of trying and seeing the result that it may bring and improve the posture. And if you comply with exercises, it also helps to improve the appearance of the curve. It doesn't correct scoliosis itself, but with the help of the strengthening of the muscle and the stretching of the shorter muscles on the convex side, what I noticed that just the appearance of the trunk becomes better, and then people just become motivated by pain relief and postural correction and appearance, and then they just follow the Schroth.
Yeah, for sure. So I'll say anecdotally, some of the patients that I've seen that ascribe to Schroth, they come in and whether it's because of the Schroth method, because of the type of person who would do the Schroth method, which is one of these more time intensive and intense physical therapy methods, they seem to be doing very well. Like they have a strong core musculature, a strong trunk that supports them, and even though their curve might be pretty pronounced, they say, I have occasional back pain here or there. I'm just coming in to check in because I know that I have scoliosis. I want to make sure it's not progressing. I want to, I come in every year or so just to get a check in, but overall they're doing well. And I think that speaks to not only the benefits of the Schroth method on building that core and support, a solid trunk to support the spine, but also it's probably there's a type of person out there that really that's the type of person who does well with scoliosis. Also anecdotally, my patients who do yoga and Pilates and really adopt those types of exercise and make them part of their day-to-day, those are the patients who are doing best, even if their scoliosis is totally out of whack. And they're staying active, they're engaging their core throughout the day, and as a result, they're able to support it. It's when we get, whether it's because we get a little more sedentary with older age, there's things that we like to do that we can't do anymore for whatever reason, or if it's a feed forward effect from pain stopping you from doing those activities, and so you do less activity, and then over time you find that you're doing less and less and less, and then that's exacerbating the pain. That's sometimes the case, but it's patients that are active, engaged in a program like doing a yoga or doing a Pilates, programs focused on that core strengthening and core health, like a Schroth method, those patients seem to be doing like fairly well despite what the X-ray looks like. In terms of other treatment options that you could pursue along these lines, so trying a period of time of medication, whether it's we like to say take medications as needed, especially anti-inflammatories. Over a long period of time, they can have detrimental effects on your stomach. But the reason that we would prescribe them or have you take them is that so you can do these type of activities a little more easily, so that you can start to do the activities that engage your core and improve the strength of your core and your trunk. So if you're in pain, you're not going to do those things. But if you can get that pain under control, you'll be more effective at doing exercise, pursuing a physical therapy program, etc. Some other important things that I talked to about with my patients is the importance of maintaining good bone health. So obviously, patients get older, your bone quality goes down, particularly older ladies, just because of the postmenopausal changes and the effect that has on bone health, which I think we're getting better and better at understanding and addressing in the primary care physician's office. But if it's something that you're concerned about and it hasn't been addressed, you definitely would be able to go see your primary care doctor. Maybe they would refer you to an endocrinologist. At HSS, we have a metabolic bone service. These are important steps to take to maintain good bone health so that you don't end up with compression fractures or sort of, things that can change the natural curvature of your spine, structural things that could change the natural curvature of your spine and accelerate scoliosis. And we talked about the benefits of physical therapy, and that's usually the first place to start for a lot of patients if they're not doing these other things. And if that stuff fails, then other conservative treatment options include injections. Oftentimes we target the facet joints, or if there's a particular nerve that's being pinched that we think would be amenable to an injection, we can try that if that's the primary issue that you're having. If it's pain down the leg or pain at certain part of your back, we can try and target those things with injections, whether it's the facet joints in the back, or even very rarely trigger point injections. Not something that I typically send patients for, but they can have a period of relief, with the idea being that after you have one of these injections, it's going to allow you to do things that otherwise support the spine. So it's going to allow you to participate in physical therapy and other exercises. That's one of the main reasons that we suggest people try injections. And oftentimes, sort of the last thing that happens is patients end up compensating for their scoliosis by how they stand. And I mentioned this previously. Maybe you're flexing your knees so that you stand, if you're pitched forward, you flex your knees to stand upright. You just tilt your pelvis back. The ideas behind physical therapy and Schroth is to allow those muscles to function more easily and allow you to stand up a little bit more easily in the world without so much pain. So those are kind of like the non-surgical treatment options. And our physical therapists at HSS and Maria, they do such a good job with not only diagnostic work, they oftentimes, can figure out really well what the generator of the pain is and address that thing so specifically, whether it's through specific exercises or other types of treatment modalities that they have, electrical stimuli. I don't know, Maria, how much you use any of these, but ice and heat are just standbys, and they're sort of the original go-to on relieving muscle pain or addressing soreness, muscle soreness. I don't know if you can speak to that a little bit.
I don't use no other modalities, but just the manual therapy. Just manually release the tense muscle, improve mobility in hips. We find that if there is decreased mobility in the hips, there is much more stresses go through the back. So the relief back stresses, we improve other joint mobility, strengthening of the hips that helps you also to stand upright.
So I see that there's a lot of people in the Q&A asking about life after surgery, but right before we get to that, why don't we talk about briefly, how do you determine if a patient might need spinal fusion surgery, and speak a little bit on what that is.
Oh yeah, absolutely. So So spine fusion surgery is sort of the end of the line when your pain is too bothersome or you've developed a progressive curve or you're not compensating for the curve that you have. And it's primarily based on how you're doing. So like I said, a lot of patients have a bad curve, they have a bad deformity, but if they're doing okay, they're getting by sort of through their, with their day to day, they, they may not be a candidate for surgery. There's other things that we look at as well, including bone health and bone quality, and that is another consideration. If you're getting to that point, I can't stress this enough. You're getting to that point where you're starting to consider, maybe I need, you have scoliosis, and maybe someone has suggested it, that you have surgery of another provider, or you're thinking about like, do I need surgery for this? Getting your bone health, sort of improve to what degree you can with either medications, additional vitamins, or seeing someone who can help you do that, that's going to be paramount, because that's going to ultimately help with your outcome after surgery. If you have good, strong bones, or bones that, are as strong as they can be, it's so much better for us, since we're trying to achieve a fusion, which is bone growth between those levels, if the bone health is of, is optimal quality. Obviously, you need clearances from other specialists. We need to make sure that first and foremost, you're safe to undergo surgery. And that's the conversation that you have with your surgeon, and also your primary care doctor, that, is this appropriate? Is this appropriate next step? Because while spine surgery is can be very effective for scoliosis deformity, especially or even in elderly patients, it's not without risk. There's a risk of blood loss. There's a risk of needing additional procedures in the future. There's a risk of not, improving to the degree that you might hope. So those are other considerations that go into whether or not you need, spine fusion. And then the other thing to consider or keep in mind is that the goals of the surgery are really not necessarily to straighten out that S curve in the front, but really to stabilize the curve if it's progressive, to give you good balance where your head and shoulder, your shoulders are level, hopefully your pelvis is level, your head rests above your pelvis when we're looking at you from the front, looking at you from the side. And so there's various ways that this is accomplished, either through, doing inner body grafts or putting in cages into the front of the spine to help with the alignment. More often than not, it'll be a large, screws and rods in the back as well to help with some of the correction, as well as taking out some bone from the facets, doing what we call osteotomies, which basically means we cut bone to help us realign the spine a little bit. But ultimately, the goal is, even if you don't end up straight as an arrow in your spine, is to get you to a point where that spine is not seeing those loads and forces, and that your balance, looking at you from both, the front and the side, is adequate. So even if it curves up to the top, if you end up with, fairly level shoulders and your head is over your pelvis looking at you from the side, then that's sort of the goal of surgery, really.
Great. I'm just going to read a little bit about what people are saying in the Q&A. So
yeah.
We have a Harrington rod from a while ago. They have hardware. So I want to talk a lot about, how to deal with life after surgery, how to live the healthiest, safest life you can. And, what are your top tips for exercising, for just day-to-day life, maybe, sitting at your desk. I know you said yoga and Pilates, things like that, core strengthening are good. And obviously we want that physical therapy if we can. But just more tips for people with these with the rods.
Yeah, absolutely. So the best advice is to remain active, eat well, live a healthy lifestyle, keep your weight under control. Also avoid, so you've learned, I'm sure anyone out there who's had spine surgery or scoliosis surgery, you learn about the BLTs, no bending, lifting, and twisting. Like, that's sort of a blanket statement that we say right afterwards to protect the hardware that we put in, to make sure that we don't have any screws pull out from bone, or if we don't have at the top of top of the fusion, that things don't start to pitch forward a little bit more, because flexing above the spine can cause that sort of breakdown to accelerate, since everything else is solid. So maintaining good body mechanics over the course of your lifetime. Thinking about avoiding excessive bending, lifting, and twisting. Obviously, if you're feeling good and you've healed up well from a scoliosis surgery, if you're having no problems doing those things, then that's fine. But you should be aware of using good body mechanics. So that means, maybe bending at the knees and hips rather, to pick something up off the ground rather than bending at the waist and flexing forward like that. Avoiding excessive twisting motions that might just cause you, it may not do damage to the hardware that's there, but it might cause you to have an increase in pain, which is to your detriment. Dr. Dowdell, welcome. How are you?
Sorry to join you guys late. I just had a busy clinic, but
No.
Dr. Shia is doing a fantastic job for me listening to him right now.
No worries at all, man. We're sort of wrapping up here at the end. I turn it over to you since you're just joining in. Do you have any top tips for living a safe and healthy life after a spine fusion surgery? What are you telling your patients?
So pretty much what I'm telling my patients is they have to be very cognizant of the positioning of their body. Okay, so that means the simplest things of positioning your body in a chair, positioning your body in bed. I don't want you to put up several pillows below your head because that's what you're used to doing in the past. You have to be very cognizant of the fact that there's a chance for complications with this surgery in the future, what we call proximal junctional kyphosis. What that means is breaking down the level above your surgery. So you have to be very careful to not try to bend over the same way you normally did, not to try to put your back or your head in a pitch forward position, because that can increase the risk of that happening in the future. So number one, keep your core strong. Number two, be cognizant of your body position. I think the surgery is worth it. I think that it makes people's quality of life better. It does carry a high rate of complications, specifically if you're not careful about your positioning post-operatively. I think that's vitally important for this kind of surgery.
Yeah, that's a great point. I mean, I think that is something that we probably don't stress enough as spine surgeons too, is being cognizant of the fact that once you have screws and rods in there and it's a solid bone after you've fused those levels, the next level above is the one that sees all the stress. So if you're constantly reaching forward, or if you're propping yourself up on pillows or bending forward to do things like that, the next level above is the one that's seeing all that new stress if everything else is stable. So you end up, potentially breaking that down quicker and maybe even needing another surgery in the future, or at least causing a place where there's another potential pain generator. So I think that's a great point, James.
All right, great. And let's find some other questions in here. Someone mentions the Alexander technique. I'm not sure what that is. Maria might know, or anyone. They said, is that helpful?
I'm actually not familiar with the Alexander. Yeah. Go ahead. Sorry.
So basically, it is also postural exercises, and many of my patients, I never actually practiced or exercised myself, but many of my patients do say that they feel better doing their Alexander technique exercises. Basically, these are postural exercises, as I understand.
Okay, great. And I know that people are asking about, where to find a physical therapist that focuses on scoliosis. So we can send out that information on how to contact your physical therapist and find someone that can help you with that. Let's see. So my primary care has diagnosed my pain as, I'm not sure what that says, impingement syndrome. Is that associated with scoliosis? Costal.
Osteoiliac impingement. So it sounds like that's a fancy way of saying that the rib is pressing on the pelvis because of the curve that you have. So certainly that could be a pain generator. And if that is so severe that it's sort of dictating your life, or maybe this is, if it wasn't a problem before and now it is, it can be an indication that your curve is progressing, then, that would probably be an indication to go see a surgeon and at least get some x-rays, talk to them about what the options would be, and then get an exam sort of focused on whether or not that is the generator of the pain, because certainly you can have, whether it's the muscle imbalance, or typically we see the pain on the convexity of the curve or the outside of the curve where those muscles are stretched you know, or you have that increased rib hump. A lot of more often than not, patients are having pain on that side, but certainly back pain or pain at a certain site merits additional workup. So certainly that could be one of the things that's causing pain, is just that you have contact of that rib with your pelvis because of the degree of your curve.
And sorry if I missed it before, but Evan, have you talked about the fact that they can have pain on the concavity of their curve if running down the leg because of foraminal stenosis? If we discussed that already, then I apologize.
Yeah, no, that's a great point. I think it bears repeating, but we talked about that as well. The types of pain are different. So, you know, that's where the, you know, advanced imaging and MRI and getting a good exam and taking a good history from the patients is so paramount, because it may be, certainly patients with scoliosis can have back pain, but yeah, on the inside of that curve, I got my little non-scoliosis spine. If you got a curve like this, the nerves come out of the foramen right here. So if they're getting pinched down and you've got a curve like this, then that can be another source of pain, or the radicular pain that we mentioned before, running down the leg. And sometimes it's a matter of a small procedure, not necessarily addressing the entire curve or trying to do a big fusion, but addressing the thing that's bothersome, if it can be done effectively. And there, you know, there's a lot that goes into that in terms of the evaluation, looking at x-rays, other imaging, whether it's a CT or an MRI, to determine if you would be a candidate for a smaller procedure if you have scoliosis. But it really depends on your symptoms and what their chief complaint is, which I always think is the most important thing when I see a patient, is what do they really come in here for to see me about? Is it because they have a big curve, or are they having leg pain, and that maybe that could be addressed with a small procedure?
All right, great. And I know you've been preaching bone health this whole time, but so can osteoporosis, can that cause the screws to come out of the spine?
Absolutely, it can. Yeah. So essentially what you're doing is, if you're putting in screws in the bone, that's your anchorage point. If the bone is stronger, you have a stronger anchor point. If the bone is weak, the anchor could potentially pull out. Okay. So with scoliosis surgery, there's usually long construct fusions. There's a lot of stress that are put on these screws. And if you don't have a strong anchor point, they could certainly pull out. Now, there's things we could do to avoid that. Number one, there's a couple things I could think of right at the top of my head. Number one is, before we do the operation, getting your bone stronger. So having a bone building agent, something like Forteo or Prolia are some of the medications we can use for that. And that could be a 6-month process before we do a surgery to get your bone stronger. But that's very important for a successful outcome after surgery. A couple other things we could do during the surgery is we can use cement augmentation on the screws. At the top of the construct, the screws at the top, we can put cement through the screws to potentially give them a stronger anchor point. That's one other thing that we can do. The other thing is something called a tether device. So essentially, tethering is augmenting the soft tissues above the level of the fusion, so there's less stress put at the top of the fusion construct. It's a newer technique, but what you do is you take this ligament-like structure and weave it through the spinous processes. And Evan, you can pull your model up real quick just to show them what the spinous process is, right over there. And that's at the level above where you had the fusion, to augment it, to give it additional stability. So a couple things that can be done about that. The most important one is working on the bone health, and that's medications with a metabolic bone doctor or endocrinologist. And that's going to be a 6-month long process to potentially make your bone better. So yes, it's very possible for the screws to pull out, but if we're smart about it, we can minimize that risk.
All right, awesome. I'm going to do one more question. I see a couple people asking about the injection, which I know that you spoke about for a bit, but can you expand a little bit on the injection for a nerve that is being pinched, someone's asking about, and do they need to be repeated? If the pain relief is temporary, is it dangerous if you repeat it?
Great question. So the way I think about injections is that they serve 2 purposes. It's diagnostic, so it tells us, is this the thing that's causing your pain? And it's therapeutic. Hopefully, if we inject that and we use a little bit of steroid medication, we can give you long-standing relief. So it's helpful for us as surgeons to know, well, first and foremost, our interest is to make you feel better. So if we can get you to someone who does injections and you get good, long-lasting relief from that injection, it allows you to go through your life with less pain, then that's a win. If it doesn't work, or maybe you only get a short duration of relief, then that tells us as surgeons that maybe there's a problem here that is not amenable to any other non-operative treatments, and we might have to talk about surgery as a next option. And it gives us a target for not only where we're going to operate, but what the patient can expect after surgery. If we address this thing that we know to be the problem and we relieve the pressure on that nerve, then at the end of the day, they should, they can expect to have a similar result from the injection that they had. So certainly injections are important for us for those two reasons. It gives us a sense of, confirming that that's the major pain driver. And also if it gets you some relief and allows you to get through it, and get past the point where you might need surgery, which does sometimes happen, then it's a win for everyone.
All right, and I'm just going to ask everyone here if you have any parting words before we close up the webinar. What do you want people to take home after today? If they have scoliosis, what do you want them to know? Or if they have had surgery, something that could help them, just your final words here. Yeah,
I would say the advice that I give all my patients is, because like I said before, the patients who are active and they try, they maintain a good weight and they maintain an active lifestyle, those are the patients that seem to do the best, whether it's before surgery or after. So taking that part of your life into your hands and really trying to stay active, adopting good practices where you do stay active, adopting exercises that keep your trunk strong, those are really the best things that you can do for yourself in the long term. And so that's my advice to all my patients. And I think that would be my parting words, is that you do your best to stay active. If you're having a hard time doing that, that's when we talk about medications or injections or things that can allow you to do that. But getting into a cycle where you are active, you're doing daily activities, you have a home exercise program, or you participate in something like yoga and Pilates, that really can go a long way.
Yeah, I echo that completely. And I would just say, this is a major surgery. There's no question about that. It's a big life decision when you're talking about adult deformity surgery, but the impact it can have on your life is fantastic. If you have no quality of life beforehand, you can have a quality of life afterwards. And that's very important. It's not just like you can't do anything after the surgery. You can have a quality of life, and your life can be made better after the surgery. There's no question it's a recovery. There's no question it's a big surgery, but you could be better after this type of operation. And that's very important to think about. Think about the end goal here.
All right. So I think that's all we have time for today. Thank you so much to all of our speakers. That was great. And thank you so much for everyone who joined tonight. If you have any other questions, you can always send us an email at pped@hss.edu. Otherwise, we'll send out the link to our YouTube.